Thank you, and welcome to this presentation on hepatitis C elimination in Africa, the current situation in the time of DAAs. My name is Sabin Nsanzimana. I'm from Rwanda, and I'll be presenting some experience from Africa, but also the case of Rwanda and how we established a control program, how we started screening people, treat and cure, and how we went through the journey of elimination of hepatitis C. And we are about to achieve through partnership, coordination, leadership, and the other factors that we're presenting over the next 15 minutes. Again, welcome to this presentation. The global burden of hepatitis C is actually a new challenge for many countries. We've been used to control HIV, malaria, and tuberculosis over the past 2 decades and more. But what we are seeing here on this presentation is actually that in the past 5 years, we've been seeing hepatitis C becoming a new challenge, actually taking over in terms of death we are recording in different countries. And not only in Africa, but the global context has changed with HIV, tuberculosis, and malaria actually being controlled, a few people dying from these diseases. But hepatitis C is taking a lot of lives, as you can see, and is likely to continue if nothing is done. But I know many countries are doing something to change this trend and this situation. It is also estimated that 5% of Africans live with hepatitis C actually being infected. This is estimated to be about 32 million of people, and is one of the highest prevalence in the world. Other countries, other continents are also affected, but differently. These are not the latest data, because it's not even easy to get these informations. But what are we doing to change these situations? From the global context, by establishing national strategic plans, by working on the pharmaceutical industries, what are the drugs available, diagnostics, and what are countries committing in terms of money, leadership, and systems to change this situation. The World Health Organization has been delivering key documents and guidance over the years. Every year, there's something that is produced, but how are we moving from documents into implementation, into changing lives? This is a responsibility of everyone. So the latest document, I think one of the most important document that was published in 2016 by the World Health Organization, is the strategy to eliminate hepatitis C as a public health threat by 2030. How are we aligned to achieve this goal that seemed impossible, sometimes ambitious, but if you think about the lives lost, it's actually not ambitious at all. It's doable if we commit to do it. And we'll see the examples on how it's not an impossible mission. It's actually something we could have done some years back. We have limited data in terms of understanding this epidemic, this pandemic actually. I'll call it silent killer that has been going through generations. And now it's our responsibility to stop it in the context of other diseases, like the current COVID pandemic. HIV is still there, malaria as well, tuberculosis, maternal child health. So we have so many challenges, but hepatitis C should be seen as a priority for elimination and without pushing it for years to come. So if we look at the incidence and how we can reduce it, we had committed to reduce the incidence by 30% by 2020, which is this year, but also new infections by 80% by 2030. That is 10 years to come. It's not far. It's just a matter of what are we doing to achieve. If we wait, then 2030 also reach us. I remember when we started this 5 years ago, I think 2020 will be really far, but it's now. So again, 2030 is not far. We also committed to reduce mortality related to COVID, to hepatitis C by 10% by 2020 and 65% by 2030. Where are we now? We're also committed to reduce increase of sterile needle and syringes provided by most at-risk people, those who are injecting drugs, are actually most at risk to acquire this virus. 200 by 2020 and 300 by 2030. We had also targets for testing. Of course, you can treat or cure those who are not tested, which is the entry point for knowing who has the disease and stop it. Committed to achieve 90% of people who will be diagnosed, know their status, aware that they have hepatitis C infection by 2030. And 80% of these will be treated. So again, to eliminate hepatitis C as a public health threat, 90% remains in our minds, diagnosed, and 80% treated. There are some countries that are doing well, but look at the numbers. The list is just so small that we can't achieve these global targets if we have only 3 countries on this list. And I will tell you what we are doing as Rwanda in the context of the continent that is most affected by many diseases, including hepatitis C. So in Rwanda, in 2018, the government established an elimination plan to be achieved by 2023. The plan was simply to screen 4 million people, aged 15 years and above, are most at risk for hepatitis C. And if we screen 4 million, expect to treat 110,000, which is 90% of the targeted populations. And by doing so, we'll reduce the prevalence of hepatitis C in Rwanda from 4 to 1.2%, which is an average of 22,000 people treated every year. And if we do so, we would reduce the mortality related to hepatitis C with an investment of $43 million. So when we launched this, some questions came out. How much money do you have to implement? Do you have systems? Do you have leadership? Do you have policy? Well, how are you going to achieve this? But the lesson we've learned over the years by controlling other diseases, well, you don't need money to start. You need just commitment and believing that you can do it. You need guidelines, you need policy, you need coordination first, then money, then the how will come after. We've learned that with $1, you can start a program. This is what we did with hepatitis C. And I'll tell you, and I'll show you the progress, what we've done, what we've achieved. Of course, we still have a lot to do. It was not an easy journey at all. So how did we start this program? How did we also think about elimination of this disease that was not funded as HIV, as malaria, as hepatitis? The first thing was, how do we find the cases? Who has this virus? Started with community sensitization and screening campaigns. I remember in 2017, when we did the first screening, we were expecting 200 people on a stadium in southern province. When we went to screen, we ended up by finding, actually, there were 4,000 people who came, and our surprise was, oh, people do really know that this virus exists, and then they're actually coming to be tested and know how and get treated. We had to screen all of them the same day, but it wasn't easy. We had to call upon on different doctors, nurses all around to make sure. From 200 plans to 4,000 expectations and reality. So we don't lose the trust between our community and the new program we're establishing. With that, we realized that actually we not achieve this by using pathologists, specialists in internal medicine, those who have been handling hepatitis over the years with interferon, with ribavirin. So we had to think about task shifting decentralization from those doctors to the nurses and now to the community health workers. We had also to talk to producers of this medicine. And I'll mention about the cost of the drugs that were complicating our situation, from $86,000 for one patient who had hepatitis C to be cured. And think how a country that just recovered 2 decades ago from genocide that took over 1 million of people, and how we're going to treat all these people who are in need. And we don't have medicine, we have patients. How do we link these two? By talking to pharmaceutical industries, by explaining our case, by showing how we're willing to start a program. Has worked with partnerships with different people who have been helping us to negotiate and to move forward, even without resources to start. So everyone needs to see that you're working. You need data, you need strong M&E that will give information that needed for planning and to show that it works. There's one country that is trying hardly, but there are some other countries who had already started. So in simple ways, we tried to show the journey we went through from 2014 by the first clinical guidelines with DAAs. For even have the medicine here, but we needed the medicine to come when we have policies and documents and guidelines and systems in place. Then we started the screening I was talking about. We started with campaigns in high-risk groups, by age, by districts. At the same time, we're collecting data and information on how we are going to be moving it in phases as we get funding, as we get people ready, and so many partners joined us throughout this journey. Until now, we're actually close to the elimination. I'll show you some statistics. So in simple ways, by working stepwise, targeting high burden populations with strong political willing, and also investment from domestic resources. There's one example I actually want to highlight, that when we started getting domestic support, so many partners, banks, private sector organizations, church leaders who came out and say, yeah, we need also to save lives by contributing to this plan. There's one example that will probably surprise you. So the Rwanda Revenue Authority was one of the first contributor to this elimination plan. Some people asked how Rwanda Revenue Authority was the first to give money. This as an institution usually that collects money from taxes and then can fund other projects. But the great answer that the leaders of Rwanda Revenue Authority provided were, actually, we need health people that will provide more taxes, we contribute to the economy. If we invest now, it's for us, for the economy of the country. We need the wealthy, we need the healthy people so that they can actually return or give back to the economies, the countries. So this domestic support and understanding and buying and ownership has helped. And we didn't create a vertical program because we knew it will cost us billions. But the first thing the government did was to make sure HIV program and the hepatitis program are hosted together. Almost the same virus with no vaccine. And so if you provide antiretrovirals, same people can provide DAAs as well. If you do a training for HIV for 5 days, you can maybe save 1 day and you train for hepatitis as well. because at the hospital level, at the point of care, these are the same people. So actually, sometimes hepatitis C was seen as benefiting from HIV resources indirectly and directly, and it worked. So I can't forget the strong external and domestic partnership that supported in reducing prices, in negotiating and packaging the proper plans and submissions. And until now, they're with us. We really appreciate it. So this slide is really so complex, but I did it intentionally to show you how, in the beginning, just the path, the flow of a patient was so complicated. From patient home to the health center, then to general practitioner, to see a specialist, then to the lab, then to access the DAAs. There were actually more than 16 steps that a patient could do to get a test, get a result, to get medicine, to do the first visit, the second visit, viral load. So it was so complex, and I leave it to see how, even if you're a patient, probably your virus won't be nice with you if you have to go through all these channels. So we made it simple, like this. What if the patient leaves home and goes to the health center and returns back home from 17 steps to just 4 steps? To achieve this, you just make some simplifications. There's someone with a virus, you can have rapid diagnostic systems and return of results, and medicine can come up to the health center without 2 or 5 specialists who will come down maybe a month for a visit. We went through all these challenges, but learning from the challenges and fixing it, and patient-centered approach worked. Now, where are we? This slide summarizes where we are. Our target, as you remember, we had to screen 4 million people. We have so far screened 3,900,000, almost achieving all we had to screen. And of this, 25,000 people have been treated and cured for hepatitis C virus. So the prevalence has reduced from 4.1 to 1.8 so far. And the cost of diagnostics also reduced. Actually, before it was more than $15. Now it's 0.7. The cost of viral load also reduced from $22 to just $9, as well as the cost of treatment. In the beginning was $86,000. In Rwanda, we accessed it through the a negotiation with manufacturers from $1,000. Now it's at $60 for an entire cure rate. And these are the medicine we've been using over time: sofosbuvir, the dipasvir, and now sofosbuvir and the cladribine. And we've seen a success rate that is interesting over the years. And so many people and the community feedback has been really, really interesting. So these are national statistics, but you see differences according to district. In the south part, there are districts who are highly affected by hepatitis C. Actually, in the north, some districts. And the differences in terms of district is actually raising a lot of questions. And we've seen the same statistics in neighboring countries where, for example, in the south, if you talk to colleagues in other health systems in those countries, they will say the same. We're seeing actually in the north some increase in cases. What you see here, if you talk to neighboring countries, here we have Uganda, Burundi, Tanzania, and Democratic Republic of Congo. So this shows how this virus has been moving from countries to the other and has no limit. And it affects the continent, it affects the entire globe differently. So why do we have this level of analysis, this granular review of data? because the intervention will be different. What you do here will be different from what you do here. And having data in real time for analysis for decision making is key to eliminate hepatitis C. Now, I've mentioned that when you have a new program, you don't need to build a new system, a new structure, because it is costly. And this is how our system has helped to package and to add on other programs in the other system. The stronger your health system, the stronger your new programs, and the better you'll be prepared for any other diseases, including the current COVID pandemic. So our basis, our strength is here at the community level. And we have people we call the heroes of health sector in Rwanda, the community health workers. They're about 60,000. In each village, they're about 3 to 4. They can treat malaria up to 70%. Actually, 70% of malaria cases in Rwanda are treated at the community level by community health workers. They're supported by health posts that have some additional health services, health centers, district hospitals, provincial, and referral hospitals. What we did in hepatitis context, we brought the services and simplified the system so that you don't need people coming from the community to come up here to the referral system to get medicine, to rather receive it here, and probably here, but not upper levels. There are so many other diseases that are managed here, and you want people to go back home and do their daily business. So I would like to pause here and thank you for your attention and the invitation to be part of this conference. Thank you.